Hello and welcome with us in the room and also for all my colleagues that are online. Thank you for coming today to this sponsored symposium by General Electric. The title of the symposium is Why Signal Quality Matters, and I wish that we will show you why is it important. I'm sure that you are already convinced, and we try to convince you about the importance of that, about ECG and also intracardiac signals. My pleasure to be here with you. I am Walid Amara, I'm based in Paris, France, and I have with me two other colleagues from Europe, Piotr Platonov, who is from Lund, Sweden, and my colleague Marco Schiavone from Milano, Italy. So it will be a nice, interesting session. I will, for the first presentation, ask Dr. Platonov to speak about digital 12-lead ECG and what is hidden behind the clinical report.
Thank you very much for this introduction and for the invitation to speak. My task is to cover the value of the surface ECG, and I am planning to give you an overview of what can be done and give you a few examples of what can we do with the digital ECG that many of us in our hospitals have a large databases, and some of us doing research with them. Some of us know, but I will show you what can be done. These are my disclosures. This is an overview. I'm going to go through the two ways of looking at ECG. The one is that working with the results of automatic measurements that are hidden behind the report that we all as clinicians get in our medical charts. And if we can, what we can do with the raw ECG signal, which is also hidden there behind the scenes, behind the report that we have. This is what it looks like. We have a number of ECGs that are stored in the clinical databases. Behind that, there is a lot of numbers. And those numbers are arranged in two ways. One is that by running automatic processing of those ECGs, which is standardly done by all ECG software, that results in a large number of measurements. The other way ECG is stored is the raw ECG file. There are different file formats depending on the manufacturer, but essentially it contains the same information. Its coordinates of every single point on the curve in 12-lead is coded with the distance from the beginning and the amplitude. And by having that, you can recreate all ECGs if you take those files outside and you have an engineer who can help you with that. So this is what it looks like. When ECG is processed automatically, it identifies the key components of the ECG signal, identifies the tops, identifies the beginnings and the ends, and measures a number of things. It measures the intervals, it measures the amplitudes of all components of the ECG signals, positive or negative. It measures areas under the curve and defines morphology as positive, negative, biphasic, P prime, R prime, and all that stuff. All that is in there, even if we don't get it in the report that is requested by the healthcare system. What can it be used for? Well, there is a number of diseases for which either diagnostic criteria or risk stratification is done on the exact measurements. This is an example of ERVC, right ventricular cardiomyopathy, and this is the disease that we work quite a lot with using standard surface ECG. One of the criteria, for example, as exemplified here, is terminal activation duration, which is measured from the nadir in S wave to the end of QRS complex. That is easily retrievable from the matrix that you get out of the system. The other thing is that inverted T waves, and these inverted T waves is also something that is coded in the majority of signal processing algorithms, again, as a number that is easily retrievable. But we can only use the ECG-based automatic criteria if we know how to define them. And epsilon wave, for example, in RVC, is one of those features that we cannot really define properly still after all those years of using the terminology. We even made a study giving the ECG patterns to a number of RVC experts to see whether they agree or not with calling the specific pattern as epsilon wave. And we were not in agreement. So basically, epsilon wave is very difficult to define. And then that leads to that you cannot measure that. My point here is that we can only use automatic measurements for something that we can define very clearly so that the machine understands that. Another way to using digital measurements is to look back in time. Most of our hospitals collect ECGs dating back few years. At some places it's just several years, at some places it's several decennia. And like in our hospital, we started using digital storage from beginning of 90s, so that for some patients with especially interesting patient group like inherited cardiomyopathy that I like very much doing research on, it's very interesting to see what happens before the diagnosis. What ECG looked like 10, 15 years before the diagnosis. And the recent study we published last year in JAHA on a pooled cohort of patients with ARVC again is where we studied every single marker on surface ECG, its behavior, first compared to the control population, this black line here. And this is an example of T-wave amplitude, for example, that was lower than in control population regardless of the age. But what is more interesting is that this red line here is the date of diagnosis. So we see that the T-wave amplitude not only goes down years after the diagnosis, but it also started to go down years before that. So that information comes from digital ECG archive. Easily retrievable, standard processing, you just get the numbers, you pull the data, and you can have the answer. Unbelievably important information source. Another way to work on the measurements is to calculate indices based on the automatic measurements. This is an example of using a transform to vector-cardiographic measurements. For some diseases, like in this case is long QT syndrome patients, for example, we know that T-wave amplitude is maybe a risk factor, maybe a risk indicator in patients with long QT2, for example. But in what lead it should be measured? There are 12 leads. Different leads show different degree of amplitude change. But if we look at the vector system, we have T-wave vector magnitude, which gives you one number. And that one number can be calculated from transformed 12-lead ECG, like we did in this study, showing that T-wave vector magnitude lower, the black line here, was a risk group, a risk factor in patients with normal QTC who had mutations associated with long QT2. So again, this information it can easily be calculated from the ECG data matrix using a little complex equation, but it's nothing special really. So you just get the three numbers and put it in the calculator and get the number. But there are things to remember and make sure that you don't get wrong, because mistakes do happen, and there is no ECG program that is perfect in calculating everything and recognizing the signal. These are the two examples of P-wave borders that, in my opinion, are wrong. This is V1 lead, and you see that the marker is set here right in the middle of the downslope of the terminal negative part. Does it matter? Maybe not really if we are only interested in P-wave duration, because P-wave duration is from the earliest P-wave beginning in any lead to the latest in any other lead. But if we want to look at the left atrial abnormality, for example, like here, then all of a sudden we are missing that completely. It may be not important if we're dealing with 1 million ECGs, but if we are dealing with 100 patients or 200 patients, then we would exclude these patients who do have or may have abnormalities that are associated with the disease. So it's worth checking. My point is, what I usually do is when I have a relatively small cohort where 1 or 2 patients may actually tip the equation to one or another side, I want to make sure that automatic measurements are right. So I want to look through the recordings and make sure that they're correct. Another problem that may occur is noise. And we started talking about that as signal quality is important. These are an example of the same ECG processed with different machines, different algorithms, but they do the same thing. They identify QRS end here and here, while likely the end of QRS is still later on. It is low amplitude, it's fractionated. Is it noise? Is it not? Maybe not noise. But what is important is that the more complex a signal, the higher is the likelihood that the automatic measurement alone may actually miss it. And if it misses the complex signals, then it's the worst affected patients may be misclassified. If we look at the P wave in the same patient, you also see it's not really healthy P wave here, right? So it's not even biphasic. It goes up and goes down and then goes up again here. And morphology algorithms, they are made for some sort of standard morphologies that are expected. The farther we are from the standard, the more difficult it could be for the computer to measure. It's worth looking at ECGs as well. Again, if it's a smaller size, look at them. If it's 1 million ECGs, we have to live with that. So it's sort of the counterbalance of the numbers. Going to the raw ECG signal processing, because it's also possible if you export the curves, the raw signal, then you can do whatever you want with them. This is an example of what it would look like if we plot the vector cardiographic loops in the based on the surface ECG. These are the P waves, and if you see here, this is how P waves are plotted in the frontal plane. It gives you a certain shape. You see this little notch at the end of the P wave, like here and here. What it is, it looks give a very clear pattern on the surface ECG. Biphasic P wave interferon leads usually are considered signs of advanced intra-atrial block. But here is another example of advanced intra-atrial block, with clear biphasic P waves in all 3 individual leads, and completely different pattern if we make a loop in a frontal plane. Doesn't matter, more research needed. But clearly, this is an example of visualization opportunities that can be done using the raw ECG signal in the database. Newer techniques coming, and Cine ECG is one of the new kids on the block that came a couple of 3 years ago, and again, becoming exceedingly used to visualize propagation spread. Here is an example of 2 P waves that are in the frontal plane expressed in the standard lead. And you see here, of course, those who can ECG can probably read that and identify that this is the case of advanced intra-atrial block. But isn't it much easier to appreciate that looking at the curve that reflects the trajectory of the impulse propagation when it first goes down, instead of crossing over to the left atrium over the Bachmann bundle, and it goes down there and then up again with the retrograde left atrial activation. Finally, a few slides at the end of my talk addressing what can be done with atrial fibrillatory signal. This is not a new technique. It's been presented in 1998 by 2 groups independently. Andreas Bollmann, some many of you may know, and Magnus Holm, who did his PhD in Lund at that time, come with exactly the same way of looking at ECG. You take the surface ECG signal in V1 in this case, you subtract the QRS complex, what is left is atrial fibrillatory signal, which can be processed for calculation of the frequency, the amplitude, and the organization index. All those are important characteristics of atrial fibrillation. It's been shown since then that derived from surface ECG and 10-second ECG snapshot in the database is enough to get an estimate of the fibrillatory process. It's associated with maintenance of sinus rhythm after cardioversion. It may be used for prediction of spontaneous cardioversion of patients coming to emergency room with recent onset atrial fibrillation. The lower it is, the higher is the likelihood of spontaneous cardioversion within a few hours after admission to ER. And it can also be used as a risk marker, because in patients with advanced heart failure and atrial fibrillation, extensive fibrosis leads to that fibrillatory process gets slower and slower. And it's been significantly associated with death from the underlying heart disease. Both cardiac death and heart failure-related death were significantly associated with a low atrial fibrillatory rate. These are just a few examples. And to summarize, digital ECGs, they allow operator-independent measurements and waveform morphology assessment, which is an advantage when we're dealing with hundreds or thousands of ECGs that we cannot afford looking manually at every single of them. Digital ECGs allow tracking of ECG substrate, which is especially important in patients with developing cardiomyopathies, so we can see backwards and forward, see what are the markers of disease progression and what are the markers of risk stratification. And new markers are available from conventional eyeballing, area under the curves, VCG indexes, and so forth. Finally, new visualization opportunities are coming, and the digital raw ECG signal can be used for that. And I intentionally left AI outside of this because there is many more things that can be said. AI is a completely different chapter. Thank you so much.
Maybe we can take 1 minute first question. If there is someone in the room that wants to ask a question, or if there is already a question on the chat, I will ask it. You didn't spoke about AI, and I think even yesterday the American College of Cardiology, they presented a study about AI for acute coronary syndromes that improves how emergency physicians working in emergency field classify patients as acute coronary syndrome even better than clinicians. So what do you think about AI in ECG in general? I believe that it's very useful. If we are electrophysiology, maybe we don't need AI. But for GPs, emergencies, etc., will be very useful. What do you think?
I think it doesn't matter whether we're electrophysiologists or emergency physicians, because AI is based on finding the patterns that human eye is not really capable of catching. So I think it's equally useful, going to be equally useful, needs to be proven for in all areas where we deal with ECG. But we're only in the beginning of the journey. It would not surprise me that we're going to see lots of ups and downs, and I want to avoid publication bias as well. We want to see negative studies, and there are not very many of them usually.
Thank you very much. So I will move now to the next presentation. I will present you now the next topic on optimization of the ablation process. Thanks, Piotr. So my topic about is more about ablation process, about EP process in our practice. These are my disclosures. I want to start by question to the audience. So maybe just raise your hand. I want to ask you, in what percentage of your practice patient do you use a mapping system? Who use mapping system for all his procedures? Only minority. For 2/3 or more, between 1/3 and 2/3, less than 1/3, and never. So maybe between 1/3 and 2/3 are your practice. And the second question I want to ask you is about, of course, building a map is always a challenge. Always a challenge working with the engineer, working between the electrophysiologists. When you are doing the map, using your mapping system, who will rely only on the mapping, will not see the potential, will only rely on the mapping? And who will look to the signals, which is great, the majority of you. Thank you very much. Maybe my topic will not be very interesting for you, because you are already looking to the system. Why I ask you that? Because actually in our era, probably we are moving from our technologies, thermal ablation, and now, as we see in this Congress, and we see that in our practice, PFA, this one kind of catheter of PFA, there are so many, and even some new ones coming to the market. And I was speaking with one of my colleagues and said to me that, in my center I can do 6 to 7 cases per day. Oh, how do you do that? I never look to the potentials. How can you do that? How can you never look to the potential? How can you don't look? You have the opportunity to look to the quality of the potential, and to look that you have this kind of atrial fibrillation. And here with the PFA, you look that you are probably having an effect on your pulmonary veins. Even in this case, the patient is still in atrial fibrillation, and then you see the effect. And even we are going faster and faster. And as you, I don't use mapping system for all my procedures, but I see some information. I see that probably I'm around the vein. There is potential, and I am affecting that. And also in my practice, I can see I had on my first 100 cases with PFA, I had around 3 cases of atrial flutter induced by my PFA. And the first time it happens to me, I just shock the patient. And the atrial flutter recurred after that. And And after 1 or 2 cases, I decided, of course, if the atrial flutter occurs, as I see that, I try to burn again, not far from the area it started. And as you see here, you have going back to the sinus rhythm. So I think that it's very important. Look into the quality of my signal. I get a lot of information there. And that's something I usually, maybe each of us, maybe we may, even if we go to social media, we will see that all electrophysiologists are posting their maps. They are posting their maps of atrial fibrillation, of VT, etc. No one is posting the signal because no one understands that. We only, of course, all of you in the room understand that, but cardiologists or manufacturers don't really understand that. But it's very important to communicate on that and to explain that. I think that improving the quality of the signal is very important because it will help us for greater precision, for shortening the procedure, the duration of the procedure, increasing the efficiency in our diagnosis and also in our treatment. The other thing that probably we may hear in this conference and all around the year, and that was my coup de cœur last year, it was the tailored AF presented at EHRA and just published 1 month ago. And what's amazing here that they proposed something, a new tool to propose for our patient with persistent atrial fibrillation. Not the simple case I showed you at the beginning, doing VP ablation and just enough, but doing more. And this randomized study, one arm is going to anatomical PVI isolation, then in case we do PVI plus lines. And the second strategy is to propose a tailored procedure. That means that they do dispersion and tailored PVI. That means that they will target some areas that are associated with fragmentation, with some of spatiotemporal dispersion. Of course, if I look to this kind of potential, I would say, as an electrophysiologist, for me, it's very important to see that there is something like a fragmented potential here and there, and probably it's interesting for me. But I would be very interested to have a tool that helps me to identify the area I should go there. And that's what's amazing, and I will let you have your analysis about that. Look into the signal that you may see there. Maybe at my personal view, it may be difficult. What is fragmented, what is dispersion, is not easy. That means that I need some I would be very interested and to have also more data on that. And probably all the competitors will come with other algorithms. And to have this data going back to my system and integrate that. So that means that I would be very interested, which is not the case actually. I'm not using Volta actually in my center, but probably as you see also in social media, a lot of colleagues are communicating on that, and to get interest on this kind of potential and to get interest on some kind of AI tool to help me to identify what are the good targets, because probably what I see with my eyes is not sufficient. I need an AI tool that helps me to identify the good target. And what was interesting there is that in this study they showed in their primary event a nice and significant reduction regarding freedom from AF after one procedure, and in the majority of the patients have 1.2 procedures only. And of course, the duration of the procedure was longer, and the majority of them was recurrence due to maybe lines that are not complete. And I think that is something that will be very, very interesting in our practice. And what we say in my routine practice, here I'm not doing mapping, is to look to the signal when doing your ablation. And that's very important. Here, my colleague Vanessa here is doing an ablation. I'm not sure if she is looking to the if she looking to this screen or looking to this screen or looking to the two screens. So I believe that you should absolutely to look to the two screen. Why is it important? Is it important because first, this helps you to identify this kind of potentials. this some fragmented potential, very nice potential. And usually I ask my engineer, target me this one, or look to that. And even here, when you look at this ventricular extrasystole coming from the aortic root, here it looks very nice, but if you look to the potential, you see that it's very early here, and that means that I ask my engineer to target the beginning here and not to target all the this signal that helped us to. And at the beginning, the map was here the most precursor, and when I asked, then that it modified the map. That means what I see will modify the way the map is done. And also, maybe in your practice, you may use a lot of tools. I will show you some examples. Of course, every day you may do RT ablation, and sometimes like using very simple algorithm like alignment interval. You can see here while reducing your extra bit, you can see here that there is a jump, and when you do the ablation, you can see that the jump just disappeared. And you see that you are sure about the efficacy. If your fellow show you just that on one image, you can confirm the success of the procedure. You can confirm that at 330 you had a jump, and now at 340 there is no jump. That means that your RT will be a success. That means that a very simple tool that you may use in your very everyday practice will help you. Of course, very useful tools like, for example, just measure length monitoring, cycle length monitoring. Just measure it, and if you can activate it very easily, just click a little. Let's click a little D on your system, and you see that you see the intervals while doing your. Just here is an atrial flutter ablation, and you see the increase of the cycle, and then the back to sinus rhythm. And one of the most important issues in your practice is noise. Because you may have noise when doing procedure, you may have noise due to all the environmental factors that you may have. And maybe you can miss that there are some amazing tools that are available that you can reduce the noise, and you can just click and suppress the noise, and just go to your system, just go to your and you see that there are some amazing filters that you may enable there or disable. Some are automatic, and then you can control them. So to arrive at the end of my presentation, I want to ask you, do you think that signal detection optimization improve mapping ablation process? Who will say yes? And who will say no? And thank you. No one said no, so thank you. I think that my take-home message is very clear, that my message that whatever the type of procedure you do, whatever if you do mapping or not mapping, or do you do PFA, or do you use AI strategies, more effective signal detection is very important. It helps you optimize your ablation process, and innovative EP recordings is part of this process. Thank you very much for your attention. And maybe if there is 1 minute for the questions, I will be happy to answer. Otherwise, I will ask Marco Schiavone to continue on this topic of enhancing atrial fibrillation treatment. And thank you very much, Marco.
Thank you. Good morning, everyone. So, I'm going to present how to enhance and how to use our tools that we currently have in our labs to enhance atrial fibrillation treatment. So, the idea is to go beyond your presentation and, prolong all the speech and all the things that you already mentioned for other cardiac arrhythmias regarding atrial fibrillation. We all know that noise in our EP labs may be painful. There is something, basically everything that we have in our lab may interfere with our ablation process, from the infusion pump to the ECG to the pulse oximeter. The EP mapping system itself interfere with an accurate recording of our signals. The ablation generator, the data acquisition system, so everything basically may generate some noise in our labs and may actually be painful for our ablation process. So we were used to some noise in the RF era because ablation catheter may induce this noise but could also be prolonged even after RF delivery. But now in the PFA era, we are used to this kind of different, high, sharp noise that disturbs the ablation process during the PFA delivery and then mostly disappear in all the channels that are disturbed for with the PF delivery. So clearly, the best approach to minimize the interference in the EP lab is trying to eliminate all the sources of noises, and that is virtually impossible. So our goal and our aim has to be to minimize those interferences, and now we're going to see how with the PRUCA, with the novel PRUCA, we have some kind of different filters and different algorithms that allows us to minimize these signals overall. Intracardiac signals are characterized by their low amplitude, and this is something that we should always keep in mind because signals are highly susceptible to power line interference, and this complicates their accurate interpretation. So whenever we are trying to minimize interferences and whenever we are trying to avoid some noise on the ECG channels, recording channels, coronary sinus, lasso catheters, and all the catheters we are currently using in our labs, we are may lose something, okay, in our signals. So the idea is to compromise the best ratio that we could get from eliminating noises while preserving the integrity of the cardiac signals. Therefore, the traditional bandstop filters, while effective, may lead to unintended signal morphology changes because they have a broad spectral impact here. So, new filters that we're currently that we're going to discover how they work in the PRUCA3 system may. The aim of these filters is to balance this strength, so maximizing noise suppression while preserving the signal's characteristics. Basically, the idea under this process here is to use an adaptive notch while preserving the harmonics detection and using all the harmonic filters that may balance the fidelity of the signals and the elimination of the noise. This we've already seen. This is an example on a east catheter from the east distal catheter with an unfiltered noisy signals to the X proximal catheters where the all harmonic filters are enabled and the signals is still clean with preserved activation. So currently, this is the setting in Centro Cardiologico Monzino where I work with Professor Tondo. We mostly have we are lucky actually because we have all basically the new mapping system, the Abbott system, the Boston system, the Biosense-Webster one, the Medtronic one, and the idea is that all these systems could collaborate and do not disturb the activity of the PRUCA system. Therefore, the instruments that you may have in your hands here are the new instruments, at least, are the adaptive filter, the fixed plus filter, and the auto filter. Basically, on the left, we have an example of how the adaptive filter works. The adaptive filter works with an auto-learning algorithm, basically reducing power line noises and minimally effective the waveform morphology. We have an example here on the left. While the fixed plus filter, I think, is the best filter to avoid the underground noise, let's say, because it has additional notch filters to remove power line frequency harmonics, other high frequency noise, and whenever you have some channels, for example, on the ablation catheter that are disturbed by the external noise, you may actually use the fixed plus filter. The auto filter is a compromise between those two because the system will choose between the fixed and adaptive filters based on the pacing configuration that you employ. This is another feature of this new system that I find it very useful in the PFA era because you have a dual real-time display to monitor eventually ST elevation in PFA. So you have your classic real-time screen with, for example, 25 speed, 50 speed, whenever you get used to. But on the right, you have the 12 lead ECG with all the channel at the speed that you want, I assume 25 speed. where you may detect easily, eventually, some slight ECG changes. This is an example of a case of us that our fellow was working with, of a 57-year-old male with dilated cardiomyopathy associated with a titin truncation mutation who presented with recurrences after a previous RF procedure of frequent RVOT originating PVCs. We chose to use the A-Fib system due to its dual energy potential in the RVOT. While we had the ablation catheter, as you may see here on the eyes images in the RVOT, during energy deliveries, this happened. You have subtle ST segment elevation in AVR and a subtle ST depression in the anterolateral leads. Okay, this is something that you may see even with your old system, but having the possibility to monitor at 25 speed in real time whenever you are currently looking at your ablation signals is very useful, because you can prematurely, let's say, and easily detect those changes in ST. And even if this is an example of VT ablation, my talk is about atrial fibrillation, but in atrial fibrillation is useful if you are using the PFA tools, for example, to ablate the mitral isthmus. This is a case actually on the RF era, so-called. So in the last year, a male 67-year-old, previous PVI with RF in 2015, which was scheduled for a EF ablation redo case with a Q-dot catheter, actually. These were the signals on the lasso catheter and the noise that you may see in the microelectrodes with the Q-dot catheter. Whenever you activate the fixed plus filters, of course, here the lasso was repositioned better in the vein, but you may see how on the microelectrodes on the Q-dot catheter, the underlying noise disappear basically with the use of the filter. This is an example of the changes in the signals, and this is another example of how you can reduce the underlying noises when you can use the adaptive filter. This is another example actually from the PFA era. A male, 55 years old, history of drug refractory paroxysmal A-Fib, which was scheduled for his first procedural ablation catheter with a varipulse system. Here you have the energy delivery from one side. For everyone that is not used to the varipulse catheter, this is basically a large spacing catheter, so maybe you could not expect to record signals that you record on the lasso catheter, on the penta-ray catheter, on the octa-ray catheter, on the grid catheter, on high-density mapping catheter that you are currently using in your practice. This was the energy delivery on the other side of the atrium. Basically, this is what you can record and see with baseline LSPV signals with no filter. Then you reposition the catheter, you activate the filter, and you see how you can detect the signals on the varipulse catheter better. Actually, here we use the adaptive filter. Same for the right inferior pulmonary vein. Here the catheter was repositioned. You see also far field here, but you may understand how you can minimize the noise. You see on the VP910 channel, you have a noise here, and here you don't have the noise because you activated the fixed pulse filter. So you have a better understanding of what's going on in your pulmonary veins, even if you are not using a high-density mapping catheter. So to come and to say something that is in continuity with the previous presentation, of course, mapping systems are important, but signals are more important. And now that you are using PFA, and there is something about the mapping system that you may want to use or you may not want to use, the better understanding of the signals is even more important, I think, in the PFA era. And here you may see how you have these disturbed channels on the coronary sinus, and this is what you get with all the PFA system. The PFA delivery is going to disturb you anyway, anyhow, in every system. But then, when you activated the filter on the coronary sinus, you see that the signals is disturbed just on the spot, on the time of the energy delivery, and then you have the clean signal if you properly use your filters on the PROCA. And this is, the post-ablation mapping. And those are the signals in the vein. The novel filters are useful also for research purposes, not only for clinical purposes. Unfortunately, I cannot present the data, but I just want to present the idea behind this, this abstract and this hopefully paper that we are going to present to HRS 2025. Consecutive persistent IF patients were treated with the pentaspline PFA catheter, so the Boston catheter, at 3 different centers were enrolled. PVI and left lateral posterior wall ablation were performed in all cases. And here the idea is that we wanted to measure the atrial fibrillation cycle length using the FARSTEN method, as elsewhere reported, from the distal coronary sinus before ablation, after PVI, and after left lateral posterior wall ablation. But also, we wanted to measure the cycle length in the left lateral posterior wall, a different zone, posing the catheter in the flower configuration into the posterior wall, to cover its entire area, to understand if there are some gaps or some differences in the area of the posterior wall, and if you may have some faster area, a slower area, for example, across the entire posterior wall. The scope of the study is beyond the, the purpose of my topic, but just to understand what we did, this is what you get when you pose the pentaspline catheter in the posterior wall. Here you may see the signals. Of course, you cannot expect the signals as we've seen previously that you can detect with the octa-ray catheter, with HD grade catheters, or with a multipolar catheter. So here you have to deal with what you have and the cleanness of the signals, and to measure the signals and the interval between the atrial fibrillation cycles at this at this speed, with a cycle of, for example, here a fast left atrial posterior wall cycle length of 182 milliseconds is essential that you have a clean signal without noises, because otherwise I'm going to guarantee, and our fellows can guarantee, because they did the measurement for all the patients and they almost went crazy when measuring all these signals. And so if you do have also noise on your channels, you're not going to get the clean signal and you're not going to get the appropriate measurement. Here you may see an example of a slow area of conduction of left lateral posterior wall, and you may see how the signals are very low in their amplitude, and here if you have noise, you're never gonna measure anything. This is an example of signals measured on the coronary sinus. For example, this was a pre-PVI measurement, and here you may see how you have these sharp signals that you can measure appropriately without any, any pain, let's say. And here is an example on how in the CS910 the filter was not activated. Of course, this was, distal activation, so in the proximal, in the CS12 you have sharper signals, but here you have also the filter activated without noise, and here you may see how you can measure this potential for these reserve purposes. Then we did PVI. In PVI, again, we measure the cycle in the coronary sinus, and to measure again the signals in the coronary sinus after posterior wall ablation, you have these clear signals, and unfortunately I can't present you the result, but you're welcome to HRS to see what we found. So, in conclusion, the new recording system allows to choose the right filter to get the best signal quality on channel-by-channel basis. So you can play with the signals and choose the most appropriate for you. And its integration with the existing hospital and EP lab infrastructure, user-friendly interface, and the compatibility with all the different EP adjacent devices make it a very useful tool, both for clinicians but also for researchers. Thank you very much for your attention.
Thank you. Thank you very much, Marco. I think we are just arriving at the end of the presentation. I think that I wish that we explained to you the importance of this quality of the signal that you explained well, including suppressing noises and cycle length monitoring, and which is our practice for all together. Thank you all for being here. Don't hesitate to get your evaluation of this session and to follow ESC 365 to see again this session. Thank you very much and see you soon. Bye-bye.